when I was young, and it was gay, straight, and bi. And what we'll do is we'll
you see that now.
Yeah, that's great.
Much better. Okay. And just on cue, recording's just started. So here we are.
Lovely. All right. So short interlude there where we were losing and gaining internet. And put that down to Scotland and the fact that it's snowing. Okay. It's not snowing now, actually. It has snowed. So yeah, so I think some of the points that you've been making, Ollie, kind of emphasizes that sort of difference in the generation. So when I was young, it was gay, straight, and bi, and the Kinsey scale. And that's how I understood a sort of continuum, really, of sexual orientation, you know, from 0 to 7, you know, where you were either totally straight or totally gay and somewhere in the middle, you know, and that in fact, in Kinsey's many thousands of research, you know, he did find out that a lot of people had experimented across the so-called divide. And this was quite sort of shocking in the 60s when he did his research. And it wasn't really talked about that much in the 70s and 80s when I was beginning to train and so on. But and then it's developed, you know, so inviting you to help me to understand sexual orientation as it evolved into the 2020s might also be useful to put up those 4 terms, Ollie, as well in the next slide, I think.
I will do so.
And sort of talk us through, as you have been really in your own experience.
As you can see, I was already smiling quite broadly, just thinking about the surprise that people had where they realised it wasn't so much the binary of you either gay, bi, or straight. You know, it was very much a fluid continuum, because it just makes me think about what people were doing behind closed doors as opposed to what people were admitting to doing for research purposes. So before I go on further, I'll put those terms that you'd spoken about. It should be on the next slide. Or this one?
That's the one. That's the one.
So I'll leave it up for a little bit while I talk, and I'll close it down halfway through, so we don't need it up the whole time, I imagine. But just for people watching can see, for a little cue. So what I will do is I'll run through each one quickly, and then I'll address how that's changed really much so from your experience to the modern day. So just before we get into that, then these key terms. So as you said, your understanding was sex and gender were quite binary and quite connected in some capacity. You know, you are either a gay man or a woman, I suppose, too. Sorry about an eyelash. Or bisexual or straight. Gay, bisexual, straight. Sorry.
I want to ask you if that eyelash real or false. I'm just playing.
Oh, I think it's just gone a little bit slow again. I heard real or false.
Okay, and so I did what you said to say. I wanted to ask if that eyelash was real or false, just for fun. Actually, in
you're going through very busy, unfortunately, Amelia. I can't quite hear you.
You carry on with your explanation.
Yeah, I will do, and then I'm sure that you'll pop back as it did before, so that's okay. And then you can ask me that again. I think you were asking me about something if you got it correct about gender and sex, and I'll explain that in now when I'm saying the key terms anyway, if I'm getting that right. So the concept that has changed. Before we thought that your sex and your gender was the same thing. You were a man or you were a woman, and then you either fancied and had sexual relationships with other men and women or the opposite sex. And it was very much that. It was simple and we kind of redacted. It was just that is the approach. And everyone has to fit into these boxes. You can't really get out of that. So the concept of biological sex wasn't really that defined as it is now. The difference is before you were assumed that your sex and your gender were a combined package. Where we've came to realize now that sex and gender are very much separate. So your biological sex is how you were born in terms of your biology, how many chromosomes you have that will build up your, in your DNA that will determine if you're going to develop a penis, if you're going to develop a vagina, and have the capacity to birth children and bore children, as opposed to having the capacity to procreate but not carry the child as a man would. So having that kind of biological, scientific, factual base of This is who you are presenting as a person. However, it doesn't mean that this is a split. This is what gender identity is about. It doesn't mean that because I have a penis, for example, I would have to identify as a man and be masculine and, I don't know, do DIY, be a builder and be muscly, or what those like stereotypical ideas are. They came to realize that gender in itself is a kind of felt sense of what we feel is okay for us. And there's a really interesting, and I could talk about this for hours, so I will be mindful of that. It's a real interesting history with queerness. And again, I'll explain what that umbrella term means shortly, because I mentioned genderqueer earlier, so probably should clarify that. There is a history of queerness that has been unfortunately erased by cisgendered heteronormative society. You know, we might want to, some people do, I suppose, put it on the patriarchy as a way of oppressing queerness. So there's been cultures and cultural identities of those who identify as a different gender than the sex that they were, you know, prescribed at birth. So, for example, in stereotypical, not stereotypical, sorry, in older kind of Native American cultures, they have something called two-spirit individuals who are those who identify as neither male or female, regardless of what the sex that they present as. So they can be born with a vagina and have, you know, all the stereotypical functions of a woman, and could be born children and breastfeed and, you know, have more you know, womanly features, and they would have X chromosomes. I want to get that right. I'm not a biologist. The female chromosomes, I'll say. But they might identify as male within themselves, in their spirit. That was kind of whitewash, I suppose, in some way, with the way that history panned out. I'm not going to get too much into that because that's a different rant for a different day. But
Yeah.
we kind of we suppress this idea of having a different gender than the sex you're presented as, and it's actually always been there. And nowadays we recognize that so much more. So your gender identity can be your felt sense as a person. And it's not just about being male or female. There are sub-identities within that. There are non-binary identities, which I would go with, which essentially means I exist on the spectrum of gender. And it kind of, it's fluid, it's ever changing. Some days I feel more manly and more feminine, you know, depending on what's going on for me that day, where I am, what I'm doing, really. And that then leads into gender expression, which is then how I show that. Some days you'd see me in a
Yes.
big long pink wig and makeup on, and some days you'll see me wearing sweatpants and a vest, you know, and not wearing any makeup and having short hair. Um, it just depends on and how I'm feeling. And some days I do feel, and this is an interesting phenomenon that I'm aware of for myself. Some days I can feel quite dysphoric with the way that I present, and it leads to, for me, to like a uncomfortable feeling. I want to just do something about it. I want to go and dye my hair or do something that makes me feel more in line with who I am and how I want to express myself. It makes you feel less oppressed, if I get the freedom to do that. But the final term on here then is sexual orientation, which is specifically the you know, the urge that we have, the sexual urge, the attraction that we have for another person based off of their sex. So it's not about their gender. So that's why you really clearly put them in two different columns, I suppose, on this slide, which is biological sex. Sexual orientation is about the sex of another person that you're attracted to. We did put labels on it because we used to assume that it was just heterosexual, so straight people, homosexual, so gay people. And now we come to realize that actually within that we have pansexual, which is people that are attracted to an individual based off their personal characteristics and qualities, as opposed to their biological sex, regardless of what genitals they might have or how their body is. You're attracted to the individual and the person and how they make you feel as a person. We have asexual, which is somebody who doesn't actually identify very strongly with having sexual urges or desires, and may not want to have a sexual relationship ever, just may not really be bothered, and that's fine. We also have bisexual, which we were aware of before, but within that, there's subcultures and sub-identities within biculture, and within, you know, again, queer culture in general, which is, I've mentioned it a few times, queer being the umbrella term for anybody that can identify on the lesbian, gay, bisexual, transgender, intersex, or as an ally to someone. So that's the LGBTQIA, the Q being queer. It's the umbrella term for everyone who sits under that.
Yeah.
So
thank you. No, that's a really comprehensive, explanation, and I think what I sort of say in my experience too, that don't let they must years ago he was singing
you're
the sort
breaking
of
up. Sorry, Amelia. I heard you up until just before years ago. I heard like a comprehensive explanation, and then there's a gap. It came through as quite bitty.
all right.
Unfortunately, it might be. If you want me to,
Can you hear me now?
I can hear you. Yeah, a little bit better. So if it's for the sake of the recording, if you wanted to type something out in the chat, I can read it out for you. Also, it's absolutely fine if that works.
Okay. Can you hear me now? And you hear me?
I can hear you a little bit. It's more so, but still not full. I'm assuming that it'll be okay to carry on and answer the question from the second slide and move on to the next one then. However,
yeah. Move on to the next slide.
Yeah, I will do. This one? About the fluidity across the boundaries.
You've talked a bit about that.
Yeah, I've started explaining this already. The only thing I think I haven't said about this one is that we've realised that it's not so binary in terms of, so I'll just explain what that means really, which is a binary, so in binary maths, if you either are a 0 or a 1, you either are a thing or you're not a thing, and there's no in between. And we were applying that theory and that approach, I suppose, to understanding people's gender identity as well as their sexual orientation. Go back to the Kinsey scale, there was stages on that to rate how straight or how gay someone was, back in the day. Whereas now we've realised that it's a fluid continuum, it's a spectrum. So if you think, maybe stereotypically going to use a rainbow analogy here, but if you think you've got the whole rainbow as a spectrum across, if this side is 100, this side is 100% straight, you very well might exist in your life where there's periods where you identify as 100% straight, then sometimes, depending on what's going on in your life, the relationships you have, you may move to feeling a little bit more gay and more attracted to men or more or other women, and or you might just value them as individuals and think, oh, they're quite attractive. I'm not interested in having sexual relations with them, but I can acknowledge that they are attractive people, and that might be a bit more towards the homosexual side of the spectrum. So we see it very much that, and it's fluid and it changes through people's lives, even if it's a very subtle nuance of a change. And we can see in modern day, it's changed a lot. So growing up now, we don't have so much people having the phenomenon of coming out to other people. It's we kind of assume and that it's okay for people to be different and gay and trans and all that, which is, I suppose, taking us into this slide, which I'll pause and allow you to kind of introduce to us if you're back.
Okay. Now, can you hear me, Ollie?
I can now. Yeah.
You can, and can you hear me clearly?
Clearly.
Yeah. Okay. Yeah. So just to finish off that discussion, there just before sort of moving into the trans discussion. I mean, many years ago, Jung coined a term called anima and animus. And what he sort of talked about really, so it kind of pre-existed the sort of stuff that you're talking about now, which was that he talked about the idea of animus being kind of masculine traits, if you like, and anima being female traits, the stereotypical, as you've described, the builder muscly or whatever, and DIY and sort of, and breastfeeding female or whatever. But and he said, that of course as human beings we've got both. So in terms of playing that piano to its full repertoire, that his view was that we've always had anima and animus in the human being. And so that's how I would see it, in that sense. And have
really
seen
interesting. Especially my experience of understanding that anima is, if I'm correct here, is usually associated with life and living, your amount of lifeness that you have, within you, your anima. And it's interesting to think about stereotypically female. I could understand the connotations between that. But that's you said it just then, people that can breastfeed, we stereotypically imagine that to be women. But actually, in this modern day spectrum and modern landscape, you might see a trans man. So that's somebody who identifies as their gender identity as male, were born and denoted female at birth. As a sex, they have a breasts and a vagina, perhaps, but they identify and present as male. They might be in a relationship with somebody who identifies as female, so we might assume that they were assumed it's a straight man, who actually might be able to breastfeed, who might be able to have children, and that's something that people are struggling with in modern day society. I think the concept of things that exist outside of the binary, pregnant men, for example, or people who breastfeed. We don't, modern healthcare in the UK wouldn't say only women can breastfeed. They can say people can breastfeed. And there's I can't remember the exact example right now. It's eluded my mind, but there is plenty of different shifts within that, how we talk about roles that people can perform. We tend not to use gendered language around it, saying like, only women can do that. We might say people can do that, or people who give birth, people who breastfeed.
If we all right, so we would clarify that the biological sex to which you were born with, that is the sex that can breastfeed. That is that's what you're saying.
You would have
so they might identify
as for it.
They might identify as male or whatever, but they were their biological sex is female, and and that is the person who can breastfeed.
Yeah, and that's a person who can breastfeed. And even the shift within that and in cultures. So this is when the more social cultural stuff comes in, which is like the idea of change and saying things correctly and being as sensitive as you can. You get a narrative split, especially in social media and the modern narrative around people and being nice and being kind. You get some people that say that's not a woman. Women. Sorry, that's not a man because they can breastfeed. They have to be a woman, which is not right. And then you'd have some people who are saying anybody can be anything, who are very open to the concept. But it's interesting around that because it's about our own beliefs about the world and if it's okay or not okay. And I'm just noticing that there's a wider narrative of more acceptance, but in the more specific cultures, family systems, for example, work-based cultures, work-based systems, or even friendship groups, perhaps, or even like your neighbors on the street, even that so much, we might not actually experience people as open-minded and as kind as you might see people preaching on the internet, if that makes sense.
Yeah, and I think also part of the issue is that people don't understand and can't separate the terms, as we've just done earlier in this video, that people, I would say, I don't want to speak for my entire generation, but, unless you go away and you read up on this sort of stuff and you talk to people very specifically about it, which takes a bit of work, and asking questions and potentially offending people sometime in the questions that you ask, but in order to unpack what's going on and understand it. So the curiosity, which perhaps decreases sometimes with age, has to be aroused.
That's really well put.
And explored further. So yes, in relation then to the current trans debate, is that the slide that's up
Yes,
now?
that
'Cause
is
I
the
can't
slide
see.
that's next.
Yeah. So one of the concerns then, having explained the terms, and I feel you've really explained them very, very well, is one of the implications of that is for sometimes actually over stereotyping, going back to, if I'm a female growing up and I'm, a bit of a tomboy, as is seen in sort of that I may be channeled into by some people who sort of see it in quite a stereotyped way as thinking, am I trans?
Yes.
And
It's
as you
interesting.
yourself have said, these things are fluid, often, sometimes throughout our lives. I mean, the degree of fluidity probably varies, but
I agree.
but so there's a slight danger, it seems, at the current, as people are trying to understand and get comfortable with these terms, of sort of channeling people a bit too quickly, parents included, teachers, whoever it is. Oh, well, if you're a bit of that, perhaps you're a man,
Yeah.
and the start getting channeled into some sort of, shall we stop the puberty? Shall we do this? Shall we do that? And ditto
It's
for
an
men
interesting
too.
debate, I think.
Mm,
In that,
yeah.
because I hear what you're saying, and there's something about
Mm,
moving away from the kind of
mm,
this cannot exist, and being quite oppressive, and it doesn't happen, we don't talk about it, kind of worldview. We may have
mm,
moved into a worldview where we are willing to
mm,
talk about it, but we might then,
mm,
I suppose it's a risk that the empirical evidence, because since we
mm,
met last time, I
mm,
did some research
mm.
into this. The
All right.
empirical
Yeah.
evidence would suggest that
Yes.
actually and this is based in America,
Mm-hmm.
the research that I read is that it was just as little as 2% of those who have transitioned, for example, and had a medical transition in line with their gender identity. So having surgery to perhaps, alter your genitals to represent the gender that you feel. So that's where you blur the gender identity and the sex,
Mm-hmm.
biological sex. You might want to change the way your body looks so it feels more in line with how your gender, so you can feel more euphoric.
Mm-hmm.
They found that it's around 2% of those are people who then regret it after, and
Yeah.
they might have been living with unsupported psychological issues more than their it's purely being based off a firm sense of gender identity dysphoria. This is when and it's not just because it's gender and sex. This is because we're humans, and humans are just really complex
Yeah.
systems,
Yeah. Yeah.
And it might
Absolutely.
be that I'm going to take the slide down a sec so you can see. It might be
Yeah.
that with the decision to have a medical transition or transition in your gender identity or live in a way that is different to how you once presented might be a offset of trauma response. Actually, there are links to sexual assault trauma, sexual abuse, neglect, rejection, and developmental traumas that might encourage someone to feel ashamed of themselves and want to change and be different. And now we have got a narrative where there is more of an acceptance around changing your gender identity or living as someone else, and that it can be appealing to someone who doesn't want to be themselves. But then I suppose it's in the care and support of that anyone, I'm assuming this is children growing up that I'm talking about. I'm also assuming that adolescents coming into teenage years, into early 20s, perhaps. You know, in the same way that we would support anyone with making difficult decisions, I would assume that there would be some guidance or some parenting or someone looking after or some peer support or the opportunity to talk decisions through without a medical
Yeah.
transition being the
Yes.
outcome, and
Yes.
to actually
Yeah.
work that one out.
Yeah.
However, going back to your question, that may not always happen. We might actually do the opposite and be really supportive and go, I've noticed, for example, you're a tomboy, and I've noticed you've been living like that since you were 6 and you're 12 now. Have you thought about the possibility that you might be trans? And it's like, okay, they're quite young to be thinking about these life-changing decisions. And I think that we can be at a risk, and I don't think it's a massive risk, and I don't think it's happening everywhere. So I'm just taking the sensationalization out of that, which is I think there could be a potential risk where we might want to be supportive, and we might, encourage people to become more binary with their decisions and say, actually, no, I am trans and I have to make that decision, and then go through a medical transition where they may not be ready. I think it's best to let people come to that decision.
I think that's the, you know, there's a sort of a bit of a dilemma there where that's right, you're pushing people, or it's, you know, there's a potential to push people into being more binary, when actually it's not like that, and I think that could have well, as the evidence that we talked about in our first conversation, you know, where lots of gay people will, you know, as a young age, express their gender in a wider range of, you know, let's put it like that. And
really well put.
you know, and you know, they're just, that's just how it is for the person. They don't need to be pushed into any particular decision about sort of transitioning to the other sex. I mean, that may be appealing for some people, but in the wide range of gay people that I have met in my sort of 60-year-old life, you know, most of them are very happy with their you know, biological sex and gender at this point, but you know, accepting the fact that societies will change and evolve.
Well, it's interesting that you're in Scotland at the moment, because they've been recently in the media around trans rights, and actually the UK government blocking a bill that was introduced in Scottish Parliament to reform the law around people being able to change their sex that's associated, and unfortunately we have to say sex in this, and this is where the legislation hasn't caught up with the kind of the research and the knowledge that we have now. We're still quite embedded in older systems, so we say sex on the birth certificate, which I would challenge in this one to an extent, because you can change the legal sex that you're represented as, which is actually your gender. You know, here we're just getting it a bit misconstrued because that's how birth certificates are made, and that needs to be changed, I think. But I digress. My point is that in March 2022, the Scottish government suggested that they can change the way that you don't have to have a psychiatric diagnosis and a medical reason to want to change your legal sex on your birth certificate. You can do it based off the fact that you identify as trans, and that's reason enough. And actually, the UK government have blocked that bill coming through recently, and there's a bit of a doodah about that, because obviously trans people feel very passionately about being allowed to be validated and seen, where there's something quite oppressive around saying, well, no, you can only transition if it's a psychiatric condition and you've been diagnosed as someone who is struggling and, you know, and needed that change so they could live better. We're actually encouraging, in Scotland now, they're encouraging a move towards not pathologizing people's gender or their felt gender identity in a way that it has to be like a concern, so they have to fix it to get better. They can just be different now.
I think probably when we're talking about the biological sex that a person is born with, there is a kind of reality base to that, isn't there? And a medical reality that
it's
you
important
need
to know.
You know, as somebody's doctor or nurse, I would need to know in order to be able to service that individual's needs properly. You know, I need to know whether they were born.
We have to ask people, you know, what's your sex, what's your gender, and what's your biology, and they'd be like, and I'd be like, oh, we need to know that. So when you go see the nurse practitioner, they know why. You know, what's the best way of helping you. It's not going to be helpful if you have a penis and don't have a womb or a cervix, and they're going to offer you the Mirena coil, which is, you know, for to be embedded in your cervix. It's not going to work if you're a man, you know. So it's about having those conversations gently with people, I would say.
Yes. So sort of that you know, there's a reality to that, I think, that needs to be in a conversation where you know, you need to know that information for, you know, order to work with the person, you know, productively.
Yes, for them as well, for their work and for their work, their care and their well-being. You know.
But okay, so let's move into then, shall we? Now we, if we look at the experiences of prejudices, assumptions, and things that have got in the way, are you happy to move towards that now, Ollie?
Yeah,
In that
absolutely.
sense?
Is that the right
Yeah.
slide with it? That
Yeah.
one there. Can you see
So
that?
I can't see anything at the moment, but I'm just going with
I can
with
see
that.
it. It should be the right one, yes.
So if you're recording it, then we've got it,
Yeah.
So yeah, and inviting you, and I know you shared generously so far some of your experience, and
Yeah.
anything further that you'd like to share before we sort of move into the sort of
Yeah.
professional issues.
So before going, so this more personal experience too. So I've already shared with you the kind of backhanded compliment then I've
Yes.
received.
Yeah.
So I go into that one too much. That does boil
Mm.
my blood. But in not so professional, but more personal, my own GP,
Mm.
who I have now changed GPs from, recently profiled me as a gay man when I attended with some concerns that were out of the ordinary. For my age, so I wasn't hoping, but I wanted to get to the bottom of it. Let's say, and it's to
Yeah.
do with I had to have a referral to urology, so it's something to do with my own personal kind of functioning there.
Yes.
And the GP refused to refer me to urology for an ultrasound, which ironically I have a letter of confirmation of the ultrasound right next to me here. Bearing in mind it's for the 1st of February when I went to see this GP in the beginning of November. And because I had a bit of a fight on my hands, he refused to refer me to urology without
Yep.
insisting that I did a chlamydia test first, because a gay man, it's more likely that I'll have chlamydia than anything else. And I was like, well, with all due respect, I work for primary care now. I understand the system we work in. I understand why you're doing and what approach you're taking. However, I used to work in sexual health and I specialize in, not psychoeducation, it's more education around the more familiar STIs. I used to deliver conferences to like 100, 200 plus people at once about testing to young people. So I'm very well versed, is my point, in how I might have contracted chlamydia, and I knew that I hadn't. And I said, and this only came about because he was stumped. He didn't know what was going on, and he really wanted to work it out. His ego was a bit involved, I think. And he really wanted to work it out and to overcome this challenge. But he was stumped, and I just said, my other half, Tomek, which is a man-sounding name, and the GP just went, oh, like as if that cleared everything up. And I was like, what? And he said, might be chlamydia then, out of nowhere. And I was like, run me through your decisions, doc. What's the thing here? Well, statistically, gay men would most likely have chlamydia. I said, okay, at the same spiel I just said to you. And then I said, so are you insinuating that the only way that I could catch chlamydia is if my other half was cheating on me? And he went, well, with gay people, just put his hands up in the air. I went, no judgment, no judgment. And I felt very judged in that moment. And I was like, what the hell? Where are you coming from here? So didn't want to get too much into that in the moment, but I did complain to the practice manager, and I've got a complaint running against the practice at the moment for that treatment. It wasn't right. And only because he refused then to refer me to urology without doing a chlamydia test, which came back negative after 3 weeks of faffing around trying to organise it. It wasn't easy, unnecessary, waste of time, resource, and waste of NHS resource, all these other things. But he was adamant that it must be. So that it interfered with the efficiency of my treatment plans. I could have had a referral to urology, as I should have done, and been seen by the end of November. It took them for December.
So that's pushed
3 months.
back. That's pushed back possible treatment by 3 months.
Yeah, 3 months. And what I had to do was I paid privately to see a consultant, the head consultant for urology, Inspire Hospital, which is obviously not NHS, it's private.
Yes.
And was seen. He prescribed me some medication and he referred me for an ultrasound that day. And didn't ask me about chlamydia and didn't ask me about those things because he knew what was going on, and he was and that got sorted out. It means I had to pay, and I could have done that initially and not wasted almost 4 months, of my life waiting, and the anxiety that caused, and the uncertainty that caused, and the anger. It was a challenge. It was a challenge.
Yes, it felt like, real strong blocking there, a real strong blocking. You have to
gatekeeping. It felt like, I can't let you get through because the reason he gave me was because on my career, on my position as a GP, I would put the risk of kind of like embarrassing himself if urology feel it wasn't a necessary referral. And it was then that became savvy to the fact that his ego and his fragile kind of masculinity was being challenged here. I think he was challenged by the idea that he didn't know, and I didn't want him to find out. I just wanted him to refer me onwards, and I didn't think he liked that, to be honest.
Yeah. I think it's yes, and then the implication too of, you know, a cheating partner, which kind of feels a bit sort of insulting in a way.
It was a bit personal, that, you know, a bit
Yeah,
close to home,
a bit
that.
personal. And would that be raised with, you know, somebody who was in a married heterosexual relationship, and that kind of cynicism
Yes,
then
exactly.
illustrated, you know, which, you know, would you consider being that rude to your patients? So
No,
there's
you know.
there's a lot contained in that sort of relative, sort of small incident, albeit that
Yeah.
it's
And
not
it's
small because
interesting,
it's your
you
health.
mentioned that, yeah, there's a lot contained in it, but that exchange was genuinely about 2 to 3 minutes of my
Yeah,
life, you know,
yeah,
and it was so packed full of things, which is why I've moved the slides onto the next slide now, Amelia, because I know you can't see it.
yes,
So I've moved them onto
yes.
what have you encountered in the counselling
Okay,
supervision work, because
yeah,
that kind of feels, as you mentioned, you wouldn't do that with your clients, and no, I wouldn't.
yeah,
But in the wider sphere, I have experienced, I'm just going to say as it is, ignorance, really, around working with people, not just with different sexual orientation or different gender identities, but just who are different in some capacity.
yeah.
I've noticed a phenomenon which occurs. It's occurred in systems I work in. It
Mhm.
occurred in the primary care system when I was a therapist there, which is an assumption that because people are different, they need to be handled sometimes too carefully, or as if they're super fragile, or as if they've got a weakness, or if they're like less than, or they need like a specific amount of babying, or like looking after, or special measures. Which some people may very well need special measures. Some straight people might need special measures. Some cisgendered people might need special measures. It's regardless of your identity. You might just need special measures that might be, slower pace. It might be easy read documents, and things that are, in the protected characteristics we can support people with. Just because somebody is gay or different in their gender identity doesn't mean they need to be handled like they're made out of cotton wool. Yeah, well,
Yeah,
made out of glass, I should say, sorry, or wrapped up in cotton wool.
walked on eggshells around, sort
Exactly.
of
Like, I didn't
thing.
know what to say to them. I didn't know how to talk to them. That's in
Yeah,
itself is insulting. They're just human
mm,
beings. They just want you to talk to them like a human being. They are. I can guarantee it. Like 100%
yeah,
guarantee it. And if they're challenged by that, it's not because they're of their identity. They're probably dealing with something psychologically. That is encouraging that. So on this slide it says things that made me wince, feel hurt, angry, or even
yeah,
fearful. It is the
yes,
ignorance I've experienced. I used to get all the gay clients who were coming to therapy not because they are gay and they want to have conversion therapy, because that is a whole different unethical conversation for another day about what conversion therapy and the
yeah,
problems of
yeah,
that. We
yeah,
don't think we have time today, but not because they want conversion therapy or to change anything about their sexual orientation. They just happen to identify as gay or as transgender or as gender non-binary. I would get all these people booked in with me because I'm gay
yeah,
and
mm,
because I'm a non-binary
mm,
individual, as if I would just have the chops to work with them because they're so different. They need someone who's just as different as they are. And that's just segregation, and it's in a more of a
yeah.
hidden, sneaky way.
Ghettoization, sort of almost.
Exactly. It's almost like we have our own water fountain to drink out of,
Yeah,
where
yeah, and I
it's
wonder also,
unprecedented. There's no need.
if there's something a bit more even sort of basic than that, really, which is sometimes professionals don't sort of want to get it wrong, you know,
Yes.
and they're afraid of getting it wrong, and actually we have to be prepared to sort of fall over lots of
Yeah. Well, you
times.
said it earlier. You got prepared to have conversations that might potentially
Yeah,
upset someone or,
yeah,
or even make you
yeah,
vulnerable.
sort of affect, like, I don't really understand what you can you explain that to me, and
Yeah,
and
exactly.
invite the individual to sort of teach them.
Yeah, and that's the thing. We do expect to be, and this is the narrative that I give when I deliver training around diversity or working along people, so people who are different in any capacity, is we do have a natural assumption as humans that we need to be like omnipotent in some way and know everything and just be the right person all the time, especially if we're in a system where we are the assumed professional, where we are in a position of power because somebody's come to us for an appointment and we are expected to be able to deliver something that will help them out. You know, we do fall into unconscious bias traps, I suppose, of assuming that we need to be right all the time. We don't upset anyone, which actually can be, like, as you're saying too, a barrier in the way of connecting with someone, because you might not want to say the thing that makes us vulnerable or runs the risk of upsetting them. And we don't want to be wrong. That's the thing. We don't want to be wrong.
Yeah, and it requires a bit of work. It requires a bit of work to go away and read and understand, you know, the individual on a case by case basis, you know. So you know, just because you meet one person who expresses themselves in one way doesn't mean you might not meet somebody else who expresses themselves in another way and requires
even if they look similar to you.
Yes,
you know,
yes.
That's the challenge, isn't it? Even if they look similar to you, don't assume things about people, is what I would say. Have some humility and ask. Just ask them. Just ask them.
Yeah. Now I'm just aware, Ollie, of the time and the are you in another meeting? Are you supposed to be in another meeting, or can we finish this off, or should we stop and
I was going to say I was going to most likely have to stop around 1:45, as I have a meeting at 11. I'm doing some clinical supervision with my supervisee, and I do have to do a little bit of prep for that because we're doing a specific piece of work today.
I wonder if we should stop now and reschedule just to have half an hour more.
That would be great.
And so let's stop recording now.